Hi, everybody. This is Erica Mello, and welcome to episode number 174 of Tough to Treat. And we are nearing the end of our summer, and hope everybody has had a nice one. And it's been hot everywhere, as we know. But looking forward to the fall here in New York City. This episode is one of our shorties, and one that I recorded for my Decoding the Complex Patient course that I'm actually going to be launching in the fall here of 2023. And it's about functional movements, and it's not in the way that you think. We always talk about functional movement patterns, how it's important to get our patients back to these functional activities. I use these in a different way in the sense that if someone has back pain and they have a problem sitting, I'm going to look at a squat, and I use different movement patterns for different patient presentations and also for different sports. You're going to look at a runner differently than a golfer, but you'll be surprised as to what I do, because I do look at it a little bit differently. And you want to look at the requirements of the movement pattern and sort of make the connection, as we love to say, between what your patient is coming in for. So hope you enjoy the episode. And Susan and I, going into the fall, are would love to have some of our listeners on the podcast with us. And if you want to come on and you want to just discuss very briefly a patient case, and we can bring you on the air, or if you just wanted to email the patient case to us and we can discuss it, without you on the air, is fine as well. But we'd love to get other people as well jumping on. It's great, you get free mentoring here, and it'll be a great way to bring together some of our loyal listeners. If you want to email us and want to take advantage of this wonderful opportunity, the email is toughtotreatpt@gmail.com. Okay, toughtotreatpt@gmail.com. Hope you enjoy the episode. Everybody, welcome to episode number 174. And in this episode, I'm going to talk about some functional movements, as I mentioned in my intro. And this is a shorty, so I'm going to be succinct with this. And if anybody has any questions, you certainly know how to reach out. So let's start with low back pain. Low back pain is very common, as we all know. We all see it. Instead of the straight plane or sagittal plane or transverse plane movements that a lot of physical therapists assess: lumbar forward bending, back bending, side bending, even standing trunk rotation. I don't tend to do that very much anymore, because I don't find it it's highly correlated with what my patient is coming in to see me for. Now, let me explain. So you can certainly, I see the persistent ones, not the acute discs. Okay, so just bear that in mind. If someone comes in and rubs their hand across their low back and they're telling me that they have low back pain when they sit, side bending in the lumbar spine and back bending is really not. I'm not going to glean anything from any of those movement patterns. You certainly can look at a forward bend, and that'll take 2 seconds to do. But I want you to think about what the patient's movement requirements are and what is in their history. We talk a lot about this. And so if someone comes in and has had a shoulder issue over the years, but it's better, they've had like a fractured rib, or they've had neck pain over the years, but it's sort of, at bay now, don't dismiss that. So you come in to the room, the patient's complaining of low back pain, and they say, "Erica, I can't sit." But they've got a lot of other movement patterns in their history. What I do generally is I look at a squat, because it's very important that you look at a movement pattern that you can assess many regions of the body at the same time. A squat is that. So if you have somebody going into a lumbar forward bend, backward bend, you're not going to be able to assess any other regions of the body well with that movement pattern. So you want to look at something else. I like the squat, because it's easy to assess. You also want to make sure you do it in varying bases of support. Susan and I have talked about this a lot on our podcast. You want to look at them in a narrow stance, a quote unquote normal stance and a wide stance. Many people prefer a wide stance squat. If they don't look right, or if they tell you the experience isn't quote unquote great when they're narrow in a squat, you have to look at the lower extremity, right? So even though they're coming in to see you for low back pain, looking at a squat with a narrow base, and if their movement pattern is off, or you see a loss of motor control, you need to possibly think about, okay, I'm going to put maybe an issue in a foot, maybe a knee or a hip on that magnet board as a potential driver, or an area that I need to look at. Okay, even though they've got low back pain, right? So the squat is a movement where you can assess all of those regions of the body. If they're pointing to their mid back, like their thorax, or even their upper back, which a lot of people do, and for various reasons, I would also look at going on the wall in a just hands on the wall, and maybe just have your patient do the same thing, put their hands normal, narrow, wide, and see what they look like, see what the experience is, put your hands on them, see if you feel any aberrant movement patterns. You can have them do a teeny mini push-up on the wall, normal, narrow, wide, stance as well with the arms, same clinical reasoning. If they don't like the experience of the narrow hands, or if you're seeing non-optimal movement patterning with a narrow base, it could be that there is something in their upper quarter, neck, shoulder, thorax, etc., that could be driving low back symptoms as well. May not, but you need to put that on your magnet board. And those are functional movements that everybody has to do. Everybody has to squat. Not everybody has to do a push-up, but we have to lean and push doors. We have to lean down and push things. So that is very functional. And so everybody is different in how they present. I don't necessarily do the wall thing or the wall push-up for every patient, but I do find it comes in very, very handy and useful when the patient has a lot of upper extremity issues in their movement history. Okay. And the persistent patients, the persistent pain ones, will have those issues in their movement history or in their past injury history. Someone tells you I have low back pain, I'm a rower and I can't sit. What rowing entails, it's a lot of upper body movement, a lot of thoracic movement. I would absolutely look at the squat, and I would look at any like a push-up on the wall or anything, or maybe just a normal narrow wide on the wall, as another movement, as another functional movement pattern to assess. You want to get the most bang for your buck in that first session, right? And so as you're going along, if you've just looked at the squat and your patient is getting better for whatever area you're treating, but they're not quite there yet, you need to go back and look and say, okay, maybe I need to assess another functional movement pattern that may reveal another driver, maybe because of an upper extremity shoulder surgery that the patient had 5 years ago, right? So that is one example. So another example is a runner. We all treat runners, and runners always have had, other knee issues, foot issues, back issues, hip issues. They all have them. I had a runner recently who's training for the New York City the half marathon, and didn't have a lot of, she was young, didn't have a lot of, issues in her history. She did have a history of low back pain, and she also had a foot issue. She was coming in to see me for hip pain. So the foot and the low back were in her history, and the running was in her movement history, right? So with runners, I always look at like lunges, right? If they can do them. Okay. So if they're coming in with knee pain and they can't lunge, obviously you wouldn't do that, right? But once again, you need to find a movement pattern that's going to relate to why they're coming in, their symptoms, and one that's meaningful, or one that's relevant for them, or one that they can give you feedback on, right? If I had a runner do a squat and there's nothing I found there, or they were not able to give me any feedback on the experience, it would be a waste of my time. So I would go right to the lunge. Just a very low, it doesn't have to be a walking lunge down to the ground, just a very sort of, 3 or 4 steps, because that will be relevant. And I have seen this time and time again with runners. They identify with lunges, not backwards lunges, but forward lunges. What you also want to check out, and what I do also quite frequently, and people dismiss this, is just the gait, right? Have your patient walk with normal stride and then very big steps. When I have patients walk with very big steps, you can see a lot of aberrant movement patterning. And it's up to you in your clinical reasoning process to figure out where that's coming from and if that's relevant to what they're coming in to see you for. So, the lunge is something I do that with, and also walking with big steps as well. I also sometimes have patients walk with weights in their hand if they're coming in to see me with back pain, for example, with walking, or any other sort of symptom with walking. People generally don't walk without anything in their hands at this point. They do have packages, so it may be worthwhile to throw a 5-pound, 6, 7-pound weight in their hand and see what they look like while they are walking. You'll glean a lot. It's a great functional pattern to look at as well. And so with my patient who was running the half marathon, she actually had hip pain. Okay, and it was a sort of, subacute. And I looked at lunge, I looked at the gait. I actually had her do a single leg stance as well, because running is one-legged. And you can do these very quickly in the office. And if you want to do a one-legged squat, you can do that as well. Those are all really important ones to look at when you have, for example, a runner. And those are great functional patterns. But I would pick the lunge first off, because single leg squat and single leg stance you're not getting the other leg involved with that. You can do them separately, but I do like that reciprocal movement pattern of a lunge to look at. And once again, try weights with the lunge as well. You'll get the upper body patterning with that. Similar to the back pain patient I had mentioned earlier, I got that with the push-up on the wall. Okay, so that's another example. Another example of a functional movement pattern I look at as almost like an ancillary or a secondary functional movement pattern is something we call sling squats, right? Those are heel raises with the knees bent and the knees straight. Okay, so you have your patient stand up straight. They do a heel raise in standing. At the top of the heel raise, they bend their knees. Keeping their knees bent, they lower their heels to the ground. They lift their heels up again with their knees still bent. And then they raise their heels up. And at the top of that, they straighten their knees out and then they lower down. Those are sling squats. The deficit I find mostly is at the bottom of the squat when the heels are raised and the knees are bent. You can see limitations of any ankle foot mobility there, especially in the talocrural joint. You can see also control in that movement pattern, or loss of it. You'll see a lot of sort of inversion patterns there. It's a great one to look at if someone has an issue or anywhere in their body, to be honest, and they have a foot issue in their history. See what you find there, and that could be a possible secondary driver to whatever you're seeing the patient for. That's a great one. I do that a lot. Really easy one to assess. I also assess that on the Pilates reformer that I have. And when patients do that, you'll see them deviate off, especially if they have a restriction in the ankle joint. They will absolutely deviate. And I don't generally do the sling squats with a normal, narrow, wide base. I do with this sort of their quote unquote normal base. However the patient stands and presents themselves, that is one that I would do. And another one that I like to look at, less so than the hands on the wall, is hands and knees. I know we dismiss that a lot as assessment, but it's a great way to look at the control of the neck and also the control of the shoulder. I use hands and knees a lot for treatment, but as a functional movement pattern for assessing upper quarter, it's not a bad one. You can see how the patient, it's a lot of weight on their arm, obviously. It's a bit more loaded than the standing one. But you could also, if you're not gleaning a lot from the standing normal, narrow, wide on the wall, what you could do is just have them go on hands and knees. It's a lot more load through the upper quarter, and see what they look like normal, narrow, wide as well. These are just other diagnostic tools that will help you add to your differential diagnosis, right? It'll just maybe raise a flag, and say, oh, I actually probably need to look at this at some point. right? You don't need to do it immediately unless it's very relevant to what your patient is coming in for. Finally, the last one is patients who come in with neck pain. You know, we seem very very interested in the neck, right? I myself have sort of a persistent neck issue, right? You know, we're always like rubbing our upper traps, and I can't turn my head to the right. Your patient says I can't look down. We tend to get very pigeonholed in that part of the body when someone comes in and says that, and understandably so. The neck is complex. It's often a source of many cervical related or symptoms manifesting in the cervical spine. But what I would caution you is that you don't just get sucked in to what the patient is telling you with regards to their neck. And I know that sounds a bit complex, but you don't want to have focus on evaluating every single level of the C-spine when your patient can't turn his head. Okay, there's a lot more that needs to happen in cervical rotation besides movement of the cervical vertebrae. Okay, I will give you an example. I had a patient 2 years ago now. He had a hard time turning his neck to the right, and he had an old clavicle fracture, and his neck was treated, and he wasn't really getting much better. And he was referred to me by another physical therapist here in New York City. And I was in his medical history, he was telling me he had a clavicle fracture. There's no fixation in there, no ORIF or anything like that, but it was basically, it scarred down. He didn't really rehab it. He was young, and that was that. But the clavicles need to move, albeit a little bit, when you turn your head. And so when you turn your head to the right, that left clavicle should anteriorly rotate and the right clavicle should posteriorly rotate. You need to assess that movement pattern, and you just need to make sure they're moving. That's all. If they're moving, move on. This guy's wasn't moving. And I actually did work around his SC joint, his AC joint, his ribs 2, 3, 4. He was fine after that. So don't miss that. Don't miss that. Don't miss that. Okay. Also, don't miss your upper rib cage. Okay. The upper ribs 2, 3, 1, 2, 3, 4. They're very, very, very related to head and neck rotation. Okay, and you could also feel the glenohumeral joints. Generally, you don't obviously want someone turning their head to the right and then elevating their shoulder joint. That's an obvious thing to see. The subtle ones are the upper thorax and the clavicle. So don't get just solely focused on C7 and above with that. Okay, really go down the shoulder complex and take a look at all the joints that form that. You may find that with some of your tougher C-spine patients that you have missed that. So you can go back and check. Hope you all enjoyed the episode. And Susan and I also would love it if you have not left us a review on wherever you listen to us, whether it's iTunes or Stitcher or YouTube, anywhere. We would love for you to leave us a review if you have found value with our content. It would help us immensely in the algorithm, and it would mean a lot to us. So thank you to all the new listeners, and thank you to all of our loyal older listeners who've been with us. My God, now it's been almost 5 years. Oh my gosh. Thank you again, and I'm hoping to see you guys in the fall.